Dr. Johnson Musomi, the Outreach Program Manager, AMREF. I'm in charge of a regional program. The outreach is a regional program. The oldest, the mother of AMREF, started in 1957. And it covers about 10 countries in Africa and is expanding to cover the whole of Africa. It deals with assisting the poor rural communities with health delivery, which is not available locally. AMREF has partnered with Computer International for a number of years, I think from 2007, on telemedicine project. The telemedicine project started in 2004, initially funded by Vodafone UK, which ended their funding in 2006. Then we made a pledge to Computer International, who took over. And through Computer International, we have been able to expand from initially 4 sites to over 40 sites today, covering Kenya, Uganda, Tanzania, a bit of Ethiopia, a bit of DRC. And we are in the expansion phase because the project is directly linked with outreach programs that deal with the patient care. So the outreach program has expanded to several countries. We have started Senegal, South Sudan, DRC. We have also started Niger, Chad, and we are on our way to Liberia. So at this expansion phase, we require a lot of ICT materials because the projects that we are dealing with require portals before and after, require internet express system, require a lot of checking, and also the patient's information. The patients who are booked for surgery, the patients who have been operated, we have to follow them through that. So, and then supply, order of supplies, and also laboratory-related tests, which can be transmitted through the computer after scanning.
What value does telemedicine add to your outreach program?
It makes the planning and implementation very easy. It allows us to know the number of patients waiting. It allows us to follow the patients after surgery, including picture, photograph taking, and transmission to the relevant information. It also makes us allow our staff to do some studies that can be done through the internet search engines.
What are the equipment you need other than the computers?
We require printers, digital cameras, scanners, USBs. We also require the super boxes. And of course, there is no limitation anymore. What matters is when we go to a country, what facilities can be required. For example, in South Sudan, in DRC, and Liberia, we require everything because basically the systems have been down because of the civil wars. We require several kits. In the next 1 to 2 years, we are likely to expand to not less than 50 hospitals in the region.
Are we welcome to see the difference?
You are welcome to see the difference, and you are also welcome to evaluate our progress and our partnership. This case, especially a patient with an accident with a broken arm or a broken leg, and an X-ray has been done, and then the doctor at the rural hospital, Mandera Moyale, cannot interpret the X-ray. And he sends that X-ray to a river hospital in Kenyatta, and the X-ray is interpreted, and the doctor in Kenyatta says what should be done. The fracture is here, do 1, 2, 3, and the patient is treated and made to live, and the bleeding is stopped, and everything is done. The same with the children when they have got diarrhea or they are dehydrated and they are very bad, and then you consult to the doctor, a pediatrician in Kenyatta Hospital, and then he tells you what to do, and then you do it, and then the child lives. It requires just computer communication. You take the photograph of the patient or the picture or the laboratory test, and then you refer it, and then you get a consultation from Kenyatta, and you are told what to do. And once you do it, the patient is fine.